Okay, so make sure you also know the autoregulation concepts. There's going to be probably one of them on these questions on the test. How blood flow to an organ remains constant over a wide range of perfusion pressures. Again, perfusion and the exchange of oxygen, blood into the tissue. For the heart, local metabolites, vasodilatory, adenosine. Okay? Lower the blood pressure, in other words. CO2, oxygen, nitric oxide, decrease in oxygen. So brain, the local metabolites, vasodilatory as well, carbon dioxide. Kidneys, myogenic and tubuloglomerular feedback. Boy, that's a long one. Lungs, hypoxia causes vasoconstriction. And then skeletal muscle, local metabolites during exercise, carbon dioxide, hydrogen ions, protons basically. Adenosine, lactate, potassium, think chalk. At rest, sympathetic tone. And then skin, sympathetic stimulation, most important mechanism for temperature control. Again, sympathetic, don't forget that's your fight or flight. Gets the adrenaline moving, I guess, to stimulate. So temperature control. Don't forget the pulmonary vasculature is unique in that alveolar hypoxia causes vasoconstriction, so that only well-ventilated areas are perfused. In other organs, hypoxia causes vasodilation. Capillary fluid exchange. Remember, these capillaries are the connection of veins and arteries, in a sense. Oxygenated blood and deoxygenated. Starling forces determine fluid movement through capillary membranes. Starling forces, if you recall. Capillary pressure, this pushes fluid out of the capillary. And then interstitial fluid pressure, this is push fluid into the capillary, interstitial. Plasma colloid, osmotic pressure, this pulls fluid into the capillary. Interstitial osmotic pressure pulls fluid out of the capillary. And then these are colloid and osmotics. Net fluid flow. And then capillary permeability to the fluid is your K factor. Reflection coefficient. In this case, it's sigma, measure of the capillary permeability up to the protein. Edema, this is the excess fluid outflow into an interstitium, commonly caused by an increase in capillary pressure, a decrease in plasma proteins, increase in capillary permeability, and increase in interstitial fluid colloid. Okay. Congenital heart diseases, right to left shunts. Early cyanosis, so if you have a blue baby, if born, you might have a right to left shunt. Often diagnosed prenatally, become evident immediately after birth when delivered. Neonatal, they call it. Usually require urgent surgical treatment and maintenance of a PDA. All right, that's your defect. And let's see, the 5 T's for a right to left shunt. You'll have a truncus arteriosus, 1 vessel, transposition, 2 switched vessels, tricuspid atresia, that's 3, tetralogy of Falley, that's 4, and then the TAPVR, 5 letters in the name. So there you go. Persistent truncus arteriosus. Fails to divide into pulmonary trunk and aortic. This is your PTA. Due to lack of aortico pulmonary septum formation. Most patients have accompanying VSD, ventricular septic defect as well. So no PTA. That seems pretty common out there. A lot of good questions on that in the homework. G, transposition of great vessels. The aorta leaves the right ventricle anteriorly and pulmonary trunk leaves the left ventricle, posterior. The separation of systemic and pulmonary circulations, not compatible with life unless a shunt is present to allow mixing of the blood. Okay. Due to failure of the aorticopulmonary septum to spiral, and remember you have to have a spiral in order for the aorta and the pulmonary arteries to be bifurcated and to move blood separately. Without surgical intervention, most infants will die within the first few months of life. The tricuspid atresia, this is where you have an absence of the tricuspid valve. That's a bad thing. Okay. And the hypoplastic right ventricle. All right. So again, the right ventricle. So you'll see right here, there is no tricuspid. It's missing. You still have the septum, but no valve. And requires both ASD and VSD for viability. Arterial septic defect, septum defect, and the ventricle septum defect for viability. So to make it work, you still need those valves. Tetralia fellow, there's 4 things that you'll need to know. All part of it, caused by anterior superior displacement of the infundibular septum, most commonly caused in early childhood cyanosis. You know there's going to be a test question on this, and then you'll see a picture of it right here. Notice the heart protruding left. All right. Left for the patient. Now this is a baby, so be careful with that. Pulmonary infundibular stenosis, most important to determine for prognosis. And then you have a right ventricular hypertrophy, in other words, a large ventricle. Boot-shaped heart, overriding aorta, and you have a ventricular septum defect. Pulmonary stenosis forces right to left flow across VSD to the right valve, TET spells, often caused by crying, fever, and exercise due to exasperation of your right ventricular outflow obstruction. So no PROV, prove pulmonary stenosis, right RVH, right ventricular hypertrophy, overriding aorta, and VSD, ventricular septum defect. So you want to do squatting. Why do you squat? You increase your SVR, your right to left shunt, and improve cyanosis. Treatment, early surgical correction. So that's your 1, 2, and 3 right here. See right here. All right. Total anomalous pulmonary venous return. Pulmonary veins drain into the right heart circulation, associated with ASD and sometimes PDA to allow for right to left shunting to maintain cardiac flow, cardiac output. Epstein anomaly, mentioned a lot, characterized by displacement of the tricuspid valve, leaflets downward into the right ventricular, artificially atrializing the ventricle, associated with the tricuspid regurgitation, accessory conduction pathways, and right side heart failure. It can be caused by lithium exposure in utero. So basically lithium in the pregnancy there, uterus. Left to right shunts, not right to left. This is left to right. Acyanotic at presentation. Cyanosis may occur years later. Right to left shunt, know that early cyanosis, left to right, later. So that makes sense. Later and early, the R and the L positions. Ventricular septum defect. This is the most common. I'll go back here. There's that. All right. So here's your ventricular septic defect. Most common congenital cardiac defect. Most common, make sure you know that. Congenital, so at birth. Right here, your VSD. right valve, left valve. So the left valve is going this way. So it's left to right in a sense. Most self-resolve themselves. Larger lesions may lead to left valve overload and heart failure. Oxygen saturation is very high, or can increase in right ventricular and pulmonary artery, primarily because why? Well, the oxygen from the lung is coming here, and then of course escapes here. VSD is the most common, then ASD, and then PDA. One of those we'll get, right? And then ASD, okay, that's the next one here. Defect in the atrial septum, so up here in the atrium. Fixed split S2, sound 2. Ostium secundum defects most common and usually an isolated finding. Ostium primum, that's what you're looking for. If you see these words on the test, that's probably going to be your ASD. Rare and usually occur with cardiac anomalies, but they are very rare. So I'm not thinking this will be a common question. Symptoms range from none, no symptoms, asymptomatic, to heart failure. Distinct from patent foramen ovale in that the septa are missing tissue rather than unfused. So it's just hasn't even grown. Oxygen saturation is high in the right atrium, primarily because you have the oxygenated blood going in there. And in the right ventricle as well, and pulmonary artery. May lead to paradoxical emboli and systematic venose emboli. Use ASD to bypass the lungs, become systemic arterial emboli. And that'll be the end of this slide, or this video.